Clinical Professor of OBGYN here at Columbia University Medical Center. It is my pleasure to introduce to you Dr. Alfred Abuhammad, who is someone who's well known to this audience and beyond. Dr. Alfred Abuhammad is currently the chair, professor, and vice dean of clinical affairs at Eastern Virginia Medical School. He's also the immediate past president of the Society of Maternal-Fetal Medicine. Dr. Alfred Abuhammad came from Lebanon, where he has his Bachelor of Science and medical degree, and then he did his residency in the University of Miami in Florida, and then his fellowship at University of Miami School of Medicine, as well as an ultrasound and prenatal diagnosis fellowship at Yale University. He has over 100 publications, over 100 book chapters. He is well known for having now the third edition for the practical guide for fetal echocardiography, and he also has the textbook First Trimester Ultrasound Diagnosis, which is currently available. And we're very, very privileged to have him give the talk for first trimester ultrasound here today. Thank you.
Thank you. Thank you very much for this really kind introduction. It's an honor for me to participate. Also, I want to thank the and the fellowship committee for SMFM that made this possible. So I was asked to speak to you about first trimester ultrasound, go through some fetal malformations, and I wanted to focus my talk on the mid-sagittal plane of the fetus and show you what you could see today in the first trimester, and hopefully excite you to start looking at the fetus earlier and earlier in gestation. So I'll start with a kind of like a little bit of a bold prediction. I really think, genuinely think, that the first trimester ultrasound will play a major role in clinical management of pregnancies in the next 3 to 5 years. And I would say by first trimester, I mean up to 13 weeks and 6 days. What do we do today with the first trimester ultrasound? We accurately date pregnancies. We diagnose multiples quite well. We do some pregnancy risk assessment with NTs and others, and we evaluate the adnexa. And that has been the scope of the first trimester ultrasound today. So estimated gestational age, as you know, if patients report no menstrual dates, ultrasound in the first or second trimester is excellent to date pregnancies. And the first trimester is the most accurate time to date a gestation. The crown rump length is also the most accurate biometric measurements to do so. And how to get it: make sure your focal zones are at the appropriate level. Magnify the image as you see here in the background image on this slide. Make sure that the embryo and fetus is in a neutral position, meaning that the embryo is not flexed where the neck is touching the chin, the chest, and measure the maximum length of the embryo from head to the breech area. And you should measure in a straight line from caudal to cranial. And as you know, the crown rump length is the most accurate between this gestation, 11 and 13 and 6. Typically, you want to use the mean of 3 discrete measurements to improve your accuracy. And you assign dates if there's a discrepancy of more than 5 days at less than 9 weeks, or more than 7 days between 9 and 13 weeks, then you use the ultrasound to date those pregnancies. Also, there's some evidence in the literature that's beyond the scope of this talk that the crown rump length has some significance with regards to growth restriction later on in pregnancy. Smaller crown rump length measurements tend to have an increased risk for this, for fetal growth restriction later on. As you get closer to 13 and 14 weeks, then you can use the traditional biometric measurements that we use in the second trimester, such as BPD, head circumference, AC, and femur length. These curves exist, but they're not as accurate in this window as the crown rump length is. Also, first trimester is ideal to assign chorionicity and amnionicity on twin pregnancies, and the accuracy is 100% if done in the first trimester. It drops a little bit as you move into the second and third trimester, as you see here. Primarily, the pregnancy risk assessment that we do is primarily based on nuchal translucency. But as we evolve, and there's a task force now that is being assembled to again visit the role of urinary Dopplers and some biometric markers, some biologic markers in the first trimester to assess for the risk of early onset IUGR, preeclampsia, and so forth. And I think as this task force, multi-society task force, kind of come up with some recommendations, we may be altering our risk assessment further in the first trimester to look for this. We also look at the adnexa. Here you see the traditional things we see in the first trimester: hemorrhagic cysts, teratomas, endometriomas, and so forth. But there's an evolving role of ultrasound. It really has evolved beyond what we have used it for. Now, especially in obese pregnant women, it affords you a window in the first trimester to look at the anatomy of the fetus and also screening for fetal malformations. So this is what I'm going to focus primarily the talk on and show you what we can see today in a systematic way for you to be able to assess those pregnancies in the first trimester. One of our fellows, graduating fellows, Dr. Romery, her thesis was on the role of early gestation ultrasound to assess fetal anatomy in obese patients. And if you look at BMIs, at least in our population, when the BMI is greater than 40, the first trimester ultrasound, when we look at detailed anatomic survey, is much better than the traditional second trimester ultrasound to complete those surveys. And if you combine the first and second in this population, is a much better approach than doing the traditional second trimester ultrasound and bringing the patient in 2 to 3 weeks later to assess to complete the anatomy if you don't see all the anatomic features. So there's an important role for the first trimester. But what is really important and where I'm going to focus the discussion today is on fetal malformations. As we are doing more and more NIPT screening on pregnant women, both high risk and low risk, we are getting results that needs to be interpreted and evaluated. And when you get an abnormal NIPT result in the first trimester, you have to rely on your ultrasound findings. So the role of the first trimester ultrasound is evolving because of this. And also, as several states have limited access to pregnancy termination, being able to make these major diagnoses in early gestation affords women more options in their decision making based on what we see in the first trimester. ISWAG, the International Society of Ultrasound and OBGYN, has a very nice document on the first trimester ultrasound, and I would look at it and read it, and has a list of anatomic planes that you need to see. And you see it's quite comprehensive for a first trimester. Now, the big question is, how good is the first trimester ultrasound to detect major fetal abnormalities? I think we have a lot of data now. Over the past 5 to 7 years, we've accumulated a lot of the data in the literature to show that the first trimester ultrasound can detect a large number of fetal malformations. Here's a list of common abnormalities that are detected in the first trimester. And you could see these are severe abnormalities, and the detection rate is actually quite high. And this is a large study by Singelaki that was published in 2011 in prenatal diagnosis that shows in a large series of 44,000 pregnancies, acrania was detected in 100%, alobar holoprosencephaly in 100% of cases, omphalocele, gastroschisis, body stalk anomaly, cloacal defects, and multiple anomalies. You could see the 100% list is fairly long, but also if you look at 50%, 70%, 60%, a lot of these abnormalities that we traditionally rely on the second trimester ultrasound can be detected in the first trimester ultrasound. Overall, if you look at the literature, this is a paper from 2017 in the White Journal. In the low-risk population, accumulating data from the literature, detection of malformation is about 32% in the first trimester. But if you go into the high-risk population, you see that we can detect about 60% of fetal abnormalities. This is a very, very important number, and this number is really also gets close to what we detect currently in the second trimester with the detailed anatomic survey. Now, from this study, looking at all this review of the literature, what is the most important factor impacting detection rates in the first trimester is having an anatomical protocol, having a protocol that you inform your sonographers, your fellows, your faculty to follow systematically during the first trimester ultrasound has significant impact on your ability. So we have generated a protocol here, and I will be happy to share it with you. I have put in Dr. Martin's email address here without her permission, but I think she would be okay. Juliana is our first-year fellow, and if you want a copy of our protocol, please feel free to email her or me. So when should you do the first trimester ultrasound? So here's a slide that shows the detection rate based on gestational age. And look what you see here. You see a sweet spot somewhere between 12 and 13 and a half weeks. So that's the optimum time, in my opinion, to schedule your first trimester anatomy surveys if the patient has an indication for that, because you are going to detect most abnormalities at the same time. If you want to rely on a transvaginal approach, the fetus is not large enough that you will miss a lot of the organs. So I'll focus during this presentation on the mid-sagittal plane of the fetus in the first trimester. So why the mid-sagittal plane? Well, I think it's really important because, first of all, this is the same plane as the nuchal translucency plane. And why this is important? Because there are standardized criteria for nuchal translucency measurements that many of you has taken like a webinar on and submitted images for review. This is the only ultrasound plane that we have today that has a standardized, approved criteria and has an established mechanism for certification. And there's a large number of physicians and sonographers that are already certified in the United States and worldwide on this. So why not use this screen for fetal malformations in the first trimester? I think it makes a lot of sense to do so. And if you look at the data from the National Nuchal Translucency Quality Monitoring Program, you see that over time, physicians and sonographers that have participated in the program has improved their ability to obtain mid-sagittal planes and nuchal translucency that comply with these criteria. So there's evidence. We have a set of standards that needs to be met to obtain this image. We have a certification exam, and we have data that shows if you comply with that, over time you improve your ability to get NTs and also to obtain this mid-sagittal planes. Also, as you know, that the mid-sagittal plane is associated with malformations. As the nuchal translucency increases, the rate of malformations increases substantially. So what should you look for in the mid-sagittal plane as part of your screening? I'm going to go through a list of things that you should pay attention to as you look at this mid-sagittal plane, and then I'm going to expand on each one of those. So first, the NT, the traditional nuchal translucency, very, very important because of the risk for aneuploidy, but also risk for congenital heart disease and other fetal malformations. Nasal bone, again, primarily for the risk of aneuploidy, especially trisomy 21 and others. The midbrain, I'm going to show you how important is the midbrain in your evaluation of this mid-sagittal plane. The maxilla, I'm going to show you why the maxilla is important. The mandible, cord insertion in the abdomen, the bladder. And then when you're done with these anatomic features, it's important to get a plane in color Doppler looking at the ductus venosus and how the ductus venosus inserts into the direction of the ductus venosus into the right atrium, and also get a 3D plane looking at the extremities. So this is what I'm going to go through during my presentation and expand on these. So first, nuchal translucency. As you know, this is not the scope of this talk, is a very important measurement with regards to aneuploidy, but more importantly, for the sake of this presentation, is with regards to fetal malformations. And an enlarged nuchal translucency should certainly prompt you to do a detailed anatomic survey in the first trimester looking for fetal malformations. And this is the association with chromosomal abnormalities, with aneuploidy, with the size of the nuchal translucency here. And it's important to look at that as you look at the mid-sagittal plane. Second is nasal bone. Here I want to highlight that the nasal bone is abnormal, not only when it's absent, but also when it's short or hypoplastic. For instance, and the nasal bone is not only a trisomy 21 marker. If you look at this large series here from Nicolaides' group, you see that an absent nasal bone is present in 60% of trisomy 21, in half of trisomy 18 and in 45% of trisomy 13. So it's an excellent marker for other chromosomal malformations other than trisomy 21 also. When you see it, you should assess the fetus for that. And here are 6 fetuses with trisomy 21 and in the mid-sagittal plane, and you could see absent nasal bone here, absent nasal bone here, but a hypoplastic nasal bone here that is not as bright as the overlying skin. And this is what's so absent, hypoplastic, or short should be an alert for you to really assess that fetus more closely for aneuploidy. Third, I'm going to look at the maxilla. And here you see the maxilla right here in the mid-sagittal plane. And why is the maxilla important? First, anatomically. If you look closely at the maxilla, as you see here in this plane, you see that there are 2 bones, right? And here's an anatomic specimen right here of the maxilla or the maxillary region. You see 2 bones. There's the vomer bone that sits on top of the maxilla, and then the maxilla is right under, as you see right here. But we look at this as 1 bone in the mid-sagittal plane. So why is it important? So here's some anatomy. Here's the maxilla, the tongue, the mandible under, and here's a fetus that's a bit flexed, showing you some amniotic fluid in the pharynx, just highlighting the maxilla in this position. The maxilla, you look at it to look at the presence or absence of a gap. The presence of a gap or a defect in the maxilla in the mid-sagittal plane is a marker for the presence of cleft lip and palates. Is present in about 96% of non-isolated cleft lip and palates, and about 65% of isolated cleft lip and palates. Present also in normal fetuses, so it's not 100% diagnostic, up to 7% of normal fetuses. And if you see a bilateral cleft lip and palate, if you have a bilateral cleft lip and palate, you would see a maxillary protrusion at the mid-sagittal plane, and I'll show you examples. So when you look at the maxilla right here in blue, look at the defect, could be in the middle, could be the proximal portion is missing, or could be the distal portion is missing. And these are some associated with the presence of cleft lip and palate. Here's an example of a fetus that is missing a significant portion of the maxilla. Here's another fetus that has a defect, large maxillary gap in the middle. All these fetuses have confirmed cleft lip and palate. And here's a fetus that has double gaps and has this protrusion that you see that's associated with bilateral cleft lip and palate, as you see on this coronal plane right here. So when you look at the maxilla in the mid-sagittal plane, pay close attention to the presence of or absence of a maxillary gap. Could be a marker for the presence of chromosomal abnormalities. Now, to fully assess the palate and the lips and the palate, there are 3 standard planes that we use. The sagittal plane looking at the maxilla. Then you go to the axial plane looking at the alveolar ridge, as you see here. And then you go to the coronal plane looking at the retronasal triangle. And the retronasal triangle is formed by the mandibles posteriorly, the maxilla on each side, and the nasal bones on top. And this shows you doing a combination of these planes can help you assess the location of the cleft palate and the size of that cleft palate. Certainly 3D ultrasound in the first trimester becomes really important also. When you see a maxillary defect, then go to a 3D ultrasound to show the presence or absence of a cleft, as you see in this fetus. Next, I'm going to talk about the mandible. So the mandible is this bone that you see right here. There are 2 mandibles, one on each side. You would see one of them in the mid-sagittal plane, as you see right here. Why the mandible is important is an excellent marker for the presence of micrognathia, as you see in the schematic drawing right here. So here's another 3D of a fetus with significant micrognathia with Prieur-Robin syndrome, and you see how small the mandible appears on 3D ultrasound. In a normal fetus, when you draw a line from the outer edge of the nasal bone coming through the edge of the maxilla, the mandible should be on the outside, as you see here. And when you get the coronal plane, as stated before, the coronal plane is made by the 2 nasal bones on top, the maxilla on each side, and the mandibles at the bottom. And these mandibles right here has a normal opening in the middle. So a mandibular gap in the coronal plane is a normal finding in the fetus. The presence of micrognathia results in the loss of this mandibular cap on the coronal plane. And that's a very important point to look for when you are suspecting the presence of micrognathia. It's really important also to note and that the first trimester ultrasound is probably the most important ultrasound for the diagnosis of micrognathia, because as the fetus grows, the significance of a micrognathia becomes less impressive as you get into the third trimester. Here's a fetus with Pierre-Robin syndrome. Look at the significance of the micrognathia at 12 weeks, and then when you scan at 26 weeks, it's barely noticeable that this fetus has micrognathia, and here's the corresponding 3D ultrasound. So keep that in mind. You have an excellent window in the first trimester to look for micrognathia. That window may not be as important later on in gestation. Next, I'm going to move to the midbrain. The midbrain is a little bit complicated. I'm going to try to simplify it here. Here's a schematic drawing showing you the anatomy of the midbrain. You have the thalamus, the brain stem, and then there are two cystic cavities, the fourth ventricle, which is called intracranial translucency, and the cisterna magna under it, separated by the choroid plexus of the fourth ventricle, and then the occipital bone here. So if we do the corresponding ultrasound in the mid-sagittal plane, you have the thalamus, the brain stem, the fourth ventricle, or the intracranial translucency, choroid plexus, cisterna magna below, occipital bone. Okay? Now, this is an axial view showing you this corresponding anatomy. So if you look at this area right here, the posterior fossa, this is at 13 weeks. And I'm going to stop it and label it to show you. This is the fourth ventricle. Choroid plexus, there's one on each side, cisterna magna, and occipital bone. And if you take that and flip it to the mid-sagittal plane, this is what you get here. Cisterna magna, fourth ventricle, choroid plexus in between. So cisterna magna here, fourth ventricle, choroid plexus in between, and occipital bone on the outside. Now, if you try to simplify this, you see that there are three cystic cavities, if you will. The brain stem is not a cystic space, but the brain looks cystic, looks anechoic or hypoechoic in the first trimester. Then you have the fourth ventricle, which is a true cystic space, and the cisterna magna. So think about this. I want to show you this image to kind of have an imprint of these three cystic cavities that look in the midbrain in the first trimester. They resemble the three-vessel trachea view, right? And the reason why this is important is absence of one of these three cystic spaces or abnormal size has a correlation for chromosomal abnormality, spina bifida, cephalocele, and Dandy Walker. So let me simplify it further. So here's a normal anatomy right here. If this area appears to be obliterated or is really small, as you see in this drawing, think about a open spina bifida or a cephalocele. If, on the other hand, this area appears to be enlarged, there's a large cyst here instead of these average-sized cystic areas, think about Dandy Walker malformation. And that's the simplest way to assess the midbrain, really, for its significance in the first trimester. So here's a fetus with open spina bifida. You can barely see any cystic changes here. The brainstem is enlarged, it's compressing. There's no cisterna magna between the brainstem and the occipital bone. That's the Arnold-Chiari effect that you could see in the first trimester. Here's another fetus with open spina bifida. Again, look at this area right here. There are no cystic changes that you see in the normal fetus. Now, the intracranial translucency and spina bifida is not a very strong marker. Initially, there was a lot of excitement that this is going to be a great screening marker for spina bifida in the first trimester, but the sensitivity overall, when you look at all the studies that have been done, is around 53%. But nevertheless, it's an important marker to look for, and if you see it, then the likelihood ratio is fairly high. Then you need to investigate, look at the spine more carefully, either by doing 3D ultrasound or by getting a sagittal view like this to look for the presence of spina bifida, as you see right here. So from the mid-sagittal plane, you can get some clues for the presence of this. Dandy Walker, on the other hand, in our experience, is a very strong marker in the first trimester. So if you see a dilation like this, or a dilation like this in the first trimester, you have to be highly suspicious for Dandy Walker. And in our experience, even though the data is not published, this is a very strong marker for the presence of cisterna magna or posterior fossa abnormalities diagnosed in the first trimester. Again, here's a normal fetus, and here's a fetus with a Dandy Walker. So other CNS anomalies, you can, in the mid-sagittal plane, you can suspect the presence of ventriculomegaly if you look at the lateral ventricles. Now, this is not an easy diagnosis to make. Why? Because it's actually quite rare. Ventriculomegaly is quite rare in the first trimester, and we don't have really set criteria like we have in the second and third trimester. But let me show you some examples. So look at this axial view right here. Look at the mid-sagittal view. You see a lot of ventricular fluid here and somewhat compressed choroid plexuses in both. Here's what the normal axial view should look in the first trimester, 12, 13, 11, 12, 13 weeks. Choroid plexuses are large. They fill the ventricles. They tend to touch the lateral as well as the medial portions, and they fill both the frontal and the occipital horns, as you see here. And that's the normal view. And these are fetuses with ventriculomegaly in the first trimester. Compressed, short, not touching the lateral aspects. Here's another fetus with ventriculomegaly. Now, if you look at the literature, there are some criteria that have been proposed, but in my experience, they're not 100% sensitive, and they require certainly follow-up 15, 16 weeks. Thinning of the choroid plexus. The choroid plexus filling less than half of the lateral ventricles. Remember, in the first trimester, they should fill the whole ventricles. The borders do not touch the lateral ventricular wall, as you see right here. There's a separation of the choroid plexus from the superior borders of the lateral ventricle, and enlargement of the third ventricle. So these are all the criteria that you can rely on from the literature. Here's a clip of a fetus in the first trimester with ventriculomegaly. Here, the third ventricle is enlarged, and look how small the choroid plexuses are. So in my experience, this is a judgment call you have to make. Certainly, follow-up ultrasounds are really important to confirm the diagnosis later on. But also, the mid-sagittal plane can make the diagnosis of anencephaly or exencephaly or true acrania here, as you see with an abnormally shaped skull. And then when you suspect the presence of abnormality, then going to the axial views can be very helpful. This is a normal axial view of a fetus, now showing the choroid plexuses, and here's a holoprosencephaly with a single ventricle, as you see right here. Here's another fetus with holoprosencephaly on a coronal view. And again, on a coronal view, you see fused thalami, and you see a univentricular system. So that's the midbrain. It's really important to understand the presence of three cystic cavities in there, two plus the brain stem. Understand the significance of absence of these cavities in open neural tube defect or enlargement in Dandy-Walker malformation. Next, the cord insertion in the abdomen. So physiologic midgut herniation, as you see here in this 3D ultrasound at 10, 11 weeks. It is noted until 12 weeks of gestation. It's almost never seen at crown rump length greater than 45 millimeters. And when you measure this in axial view, it should never measure greater than 7 millimeters. So when you look at this like this and you measure it across, it should measure less than 7 millimeters. Remember that 7 millimeter number becomes important as we look at the bladder in a minute. Why this is important? Because of the diagnosis of abdominal wall defects such as omphalocele, as you see here in the schematic drawing and the corresponding 3D ultrasound. And here are two fetuses with omphaloceles, as you see right here. Omphalocele with the liver inside, bowel in the first trimester, and here's another omphalocele. Again, the stomach is already out, liver and bowel in the omphalocele. Now, I'm going to give you a tip here. When you look at the omphalocele in the first trimester, and this is, in my experience, much more pronounced in the first trimester than it is later on. Look at the direction of the omphalocele. Typically, the omphaloceles should be centrally located, as you see in this schematics, and the bulk of the arrow, kind of like the omphalocele, is pointing in this direction. That's your classic omphalocele defect. If it is pointing upward towards the fetal head, think about pentalogy of contrail. We had a case this week, actually on Monday, of a fetus at 12 weeks with suspected pentalogy of contrail with a large omphalocele. The omphalocele is like almost pointing to the chest. The heart is still in, but very close to the omphalocele itself. If it is pointing downward towards the lower extremities, then think about OEIS complex. This is when you start thinking about cloacal exstrophy, starts thinking about skeletal abnormalities, and so forth. So the direction of the omphalocele is really important in the first trimester. So here's a pentalogy of contrail case. You see how the omphalocele is pointing, almost touching, look, is almost touching the face of the fetus. And here's the OEIS case. You see where the omphalocele is pointing downward. Here you see the bladder inside and the liver. So the direction of the omphalocele is really important. When you look at gastroschisis, Gastroschisis is also easily diagnosed in the first trimester. You see the bowel here coming out in an axial view, and here's the mid-sagittal view showing you the gastroschisis defect itself, and here's a corresponding 3D image. Now, how can you differentiate an omphalocele from gastroschisis in the first trimester? Look at the borders of the defect. So if the border is really smooth, that's an omphalocele, because remember, it's covered by a membrane. If the border is ragged a little bit or irregular, as you see right here, then think about gastroschisis. That's an easy way to make the diagnosis at 12 or 13 weeks of gestation. Next, let's move and look at the bladder. So the bladder in the mid-sagittal plane is seen in about 88% at 12 weeks and almost 100% at 13 weeks. Really important point here is that the source of amniotic fluid in the fetus is not coming from the kidneys until about 15 or 16 weeks. So you can have a lower urinary tract obstruction, you can have bilateral renal aplasia with normal amniotic fluid until about 15 weeks of gestation. It's really, really important not to get fooled and suspect the presence of kidneys if you see normal fluid in early gestation. In the mid-sagittal plane of the fetus, the sagittal length of the bladder, as you see in this schematics, should be less than 7 millimeters. Remember the omphalocele, the physiologic hernia, we said 7? Here's another 7 millimeters here. So you measure it as you measure right here in this sagittal length. Normally should be less than 7 millimeters. If it is between 7 and 15 millimeters, this is called megacystis. Anything greater than 7 is called megacystis. But if it is in this window, as you see right here, about 1 in 4 to 1 in 3 fetuses will have chromosomal anomalies. So in 24% of the case, you'll have chromosomal anomalies. But if the chromosomes are normal, then resolution of megacystis occurs in about 90%, and renal anomalies is present in about 10% of residual fetuses. So 7 to 15 millimeters is abnormal, high association with chromosomal abnormalities, but if you rule this out, there's a high chance of resolution spontaneously. Here's an example at 12 weeks. Look at this megacystis with some thickened walls. So remember, megacystis at 15 weeks, at 15 millimeters or greater than 50 millimeters, is almost always an abnormality, almost always a fetal abnormality, either chromosomal abnormalities in about 11%, but also renal anomalies in about 100% of cases. Now, determining fetal sex in the first trimester, remember it's inaccurate before 12 weeks. The accuracy increases with advancing gestation. You should be able to determine sex almost always at greater than 13 weeks of gestation. Some clues to this, you could look here at the female, the genitalia points parallel to the spine at 12 weeks, where in males, the genitalia point perpendicular to the spine, as you see right here. And that's a clue to early diagnosis in the first trimester. So now we've looked at the NC, we've looked at the nasal bone, the maxilla, the mandible, the midbrain, cord insertion in the abdomen, and bladder. It's really important to now look at color Doppler in this mid-sagittal plane and look at the attachment of the umbilical vein through the ductus venosus to the right atrium. And what you really need to see is you need to see this direction of ductus venosus flow coming towards the subdiaphragmatic vestibulum, joining the IVC and the hepatic vessels into the right atrium. Why this is important? And here's a clip of a normal fetus. The arrow points to the directions of the ductus venosus coming from the umbilical vein. So here's the umbilical vein. Look at the direction that the ductus venosus takes. This is important because if you have absence of the ductus venosus, as you see right here, the umbilical vein has no connections directly through the ductus venosus, then you have to think about chromosomal abnormalities in the first trimester. Here's a trisomy 21 fetuses where the umbilical vein directly connects to the IVC, does not connect through that channel of the ductus venosus into the right atrium. On both occasions, perpendicular attachment to the IVC has been described in the literature in many series now in association with chromosomal abnormalities. Here's 4 fetuses with various chromosomal abnormalities that have in common ductus venosus abnormalities with direct connection of the ductus venosus to the IVC. So remember what I showed you earlier. If you look at baby C here, the connection should come that way into the right atrium. Here's the ductus venosus dips downward to connect straight to the IVC. Very important point to keep in mind as you look at the color. And my recommendation is just look at the ductus venosus quickly in the first trimester to really assess the direction of flow. And finally, get a 3D volume to look at the extremities. In the first trimester, it is much easier to look at the extremities than it is later on in gestation, especially when in obese patients. Because of shadowing by ribs, because of fetal positions, here you have the ability to assess the extremities really well early on. The hands are always in front of the chest at 12, 13 weeks, and they have this features that they are close together. And the extremities, the lower extremities, the feet are almost touching also. So being able to get a 3D volume allows you to assess the segments of the extremities, the relationship of the extremities, to make sure you rule out any skeletal abnormalities in fetuses. And here's another example in the third trimester. Here you look at 12 weeks in this fetus that has polydactyly, and you can see that fairly clearly early on. In this particular patient, upon follow-up into the second trimester, it was really hard for us to find the polydactyly because of fetal crowding. Now that we've gone through the mid-sagittal plane, I want to talk a little bit about aneuploidy screening for the last, 5 minutes or so that I have. So trisomy 21, here, the list is here of what you should expect to see, but certainly what is very prominent for us is the nuchal translucency, absent nasal bone. This fetus has a cleft in the maxilla, as you see right here also. And you know about the other findings, tricuspid regurg and so forth. When you go to trisomy 18, I want to show you this mid-sagittal plane, and I want you to spend maybe half a minute looking at what we've talked about earlier and see if you can identify abnormalities that you see on this mid-sagittal plane. So clearly you can see a nuchal translucency that is wide. You can clearly see an omphalocele, right? Look at the maxilla. There's a large gap in the maxilla here. Look at the midbrain. There's a clearly a cystic sternomagna dilation, suggestive of Dandy Walker. Look at the presence of hydrocephalus and look at the absence of the nasal bone. So you could see now, you can look at this mid-sagittal plane. You have a different eye looking at it, knowing what you could see in the mid-sagittal plane and looking at the number of abnormalities that you could see. And that's a fetus with trisomy 18. Again, nuchal translucency, absent nasal bone, omphalocele, maxillary gap, Dandy Walker, ventriculomegaly. Here's a fetus with trisomy 13. A lot of fetuses in the first trimester trisomy 13 have megacystis with bladder obstruction and has bright echogenic kidneys, as you see right here. And looking at monosomy X or Turner syndromes, here primarily we look at the presence of enlarged cystic hygromas. And if you look at these fetuses here, you see the mid-sagittal plane is very telling with the large cystic hygromas. And look at this fetus here. At 12 weeks, there's a horseshoe kidney, as you see right here. And I'm showing you these examples to highlight how much you could see in the first trimester. And I'm hoping to excite you to really start looking at the fetus much more carefully in the first trimester, because in our experience, you can diagnose most abnormalities in the second trimester and the first two states. Triploidy is an important diagnosis to keep in mind because you can make the diagnosis by looking at the mid-sagittal plane very easily. If you look at the data on features of triploidy, the most common one is the presence of a head circumference to abdominal circumference discrepancy. So what you see at the mid-sagittal plane is something like this. You look at a very large head as compared to the chest, and that should be a clue to you to the presence of triploidy. Here's a 3D picture of a different fetus than the one I just showed you, again with triploidy in the first trimester. And that's at the mid-sagittal plane itself. So putting all this together, I really think the mid-sagittal plane is a good screening modality for fetal abnormalities in the first trimester. Rather than doing away with nuchal translucency, as more and more patients are opting for NIPT, we need to enhance training and focus on detection of fetal abnormalities in the first trimester. And the role of the first trimester ultrasound will expand over the next few years. As we have been doing this now for a while, and we have established a special first trimester clinic once a week to kind of put all the first trimester patients for anatomy survey in one place and developed a protocol for this. we are detecting a lot of malformations that we could see in the first trimester. So I'll stop here. I just want to put in a plug for the free ultrasound book. If you don't have it, please download it. It's openultrasound.com. Hopefully it will be helpful for you in your training, but also for your residents and students. So I think I will stop here, maybe take some questions. My apologies for the disruption in the presentation. I don't know what happened then, but we have some time for questions. I finished early on purpose to be able to answer some questions. Thank you for your attention.
All right, I would like to thank Dr. Abuhammad for this wonderful talk. Very, very inspiring because we don't do a lot of first trimester ultrasounds here, but a lot of patients do request it. It's amazing to see that what you can do these days. I'd like to open up the chat board for any questions.
So if you want to copy of our protocol, feel free to email me or email, I don't know where I can type here, email me or email Juliana, our first year fellow. So
I guess while we're waiting to see if anybody has any questions, do you have any difficulty getting reimbursement for the first trimester scans?
Yeah, very good question. So we don't, so first of all, we don't do first trimester ultrasound on everybody. So we scan patients that are getting to be scanned in the first trimester for other indications. Then we use that opportunity to look in details. So every patient that gets a scan between 12 and 14 weeks, I would say, gets the full evaluation of the anatomy. We do this on high-risk patients, also obese patients. We are billing a standard ultrasound, first trimester ultrasound, and as long as we have an indication for it, we have not been denied for that. Okay. We don't do it routinely on everybody. That's really important to share. Any questions? So maybe I'll ask myself a question in the meantime. So two common questions that I get asked about first trimester. One, how often could we do this relying on the transabdominal ultrasound versus the transvaginal ultrasound? So I can tell you probably in about 90% of the time we can complete the anatomy survey on the transabdominal ultrasound. But if we can't, we rely on the transvaginal ultrasound quite a lot. When we suspect the presence of an abnormality, we always look transvaginally because we could see way more details with a much higher resolution. Anytime we suspect a cardiac malformation, I didn't include a lot of cardiac here, but part of our protocol is getting an axial view at the level of the four-chamber view, looking for cardiac access, which we believe is an incredible marker for cardiac abnormalities in the first trimester, and then getting the three-vessel trachea view. And any issue with that, then we go to the transvaginal ultrasound. The second question that I was going to ask myself, and is displayed now, how safe is this for the fetus? So the issue with Doppler in the first trimester is primarily related to spectral Doppler, because in spectral Doppler, the energy is focused on the gate and it's placed on the fetus, then the whole energy of the ultrasound beam is focused there. So we try to minimize the use of spectral Doppler as much as possible. We follow the ALARA principles in ensuring that your MI and TI are always below 1 and use the minimal power to achieve that. And as long as you use color very infrequently just to assess the four-chamber view, to assess the ductus venosus flow, I think you should be okay, and you are within the ISWAG and the AIUM guidelines for this. So other questions, how long does it take to perform this type of sonogram? Frankly, when you become experienced, it's much easier than you think. The only difficulty is related to how do I manipulate the transvaginal ultrasound. Because the fetus moves so often in the first trimester, you always get the planes that you need to if you wait a little bit. I would say within 15 minutes, 15 to 20 minutes, you can complete a fairly detailed first trimester ultrasound.
The next question,
are we able to clear an anatomy with the first trimester? We're still doing the second trimester ultrasound now, certainly. You cannot say, the false negative of the first trimester ultrasound hasn't been worked up yet, but there are several abnormalities that we know will not appear in the first trimester. I showed you that ventriculomegaly is very rare to see in the first trimester. When we look at cases of ventriculomegaly and go back in the first trimester, most of the time we don't see it. There are several malformations, several renal malformations that are not visible in the first trimester, such as, any cystic dilations of the kidneys beyond the autosomal recessive dilations you cannot see. Multicystic dysplastic kidneys cannot be seen. A lot of the lung lesions have not been described. So I would recommend that the first trimester ultrasound is a screen for you, and the second trimester ultrasound should still be the diagnosis. Now, if you make a diagnosis of hypoplastic left heart syndrome in the first trimester, and you have the expertise, we counsel the patient and we provide the full picture of counseling, but you have to acquire the experience to be able to do so. Fadi has a question. The SMFM coding committee is looking at ways to recognize the work associated with first trimester anatomy ultrasound. The survey went to SMFM membership last month, and the results plus recommendations will be presented in the next SMFM annual meeting. I think this is great. And I don't know what the survey will show. I could tell you that in many places in Europe, based on the data that exists, the first trimester ultrasound is becoming quite important. And I would strongly recommend that you start as a fellow. I would strongly recommend that you work with your division to create a special clinic for first trimester ultrasound. Could be half a day, and start following a standardized protocol and start doing this, because in your practice in the future, this is going to become an important part of your ultrasound examination.
Dr. Abuhammad, I have another question for you. We have, when we do first trimester evaluation, we occasionally see pleural effusion, and I know it is associated with adverse pregnancy outcomes. What should we be looking for when we see pleural effusion in the first trimester, or else, rather, what else should we be looking at?
Very good question. I'll answer this with or without anomalies. So if the presence of an abnormality, we have seen a lot of kind of like hydropic fetuses and a lot of pleural effusions and some pericardial effusions in the first trimester in association with fetal malformations. And when we follow those pregnancies into the second trimester, in a large proportion of those patients, the hygroma, the pleural effusions and the hydrops disappears as you move into the second trimester. So I do not know the physiologic significance of this in the first trimester, but isolated pleural effusion in the first trimester, I think should be worked up probably for aneuploidy. And if it is isolated and there's nothing else, and if it goes away, I will be very, very assured that this pregnancy is going to be.
And along the same lines, if you see sort of signs of hydrops in a mono-di twin pair in the first trimester, do you know how frequently those cases eventually present as TTTS?
I don't a specific number, but if this is associated with some discrepancy in crown rump length and some discrepancy in NT measurements, then probably a fairly high association. Now, I don't know exactly what numbers. As you know, there's a lot of controversy about the role of nuchal translucency in screening for TTS in the first trimester, and some studies have shown no significant benefit of doing that. But certainly a hydropic fetus in the first trimester in a twin pregnancy is a significant finding. And I don't have a specific number to give, but I would say a fairly high association with problems to come. And in a monochorionic pair, probably early TTTS, I would think, is probably the most common. More common than not, I would say maybe about half the time, but I don't have real numbers and I haven't looked up that on the literature to be able.
I see there are no more questions at this time. I would like to again thank Dr. Abuhammad for this wonderful presentation. His email is listed here in the chat box. This lecture will be available for you to look at offline as well in case you wanted to go back and review it. Also, the email for their fellow is available in the presentation, so you can email one of them if you're interested in their first trimester protocol. But again, thank you so much.
Thank you. It's been my pleasure.
Everyone.
All right.